This conference will now be recorded.
Yep.
Over 100 and then So the official temperature is 100.4. A temperature of greater than 100.4, a heart rate of greater than 90, respirations greater than 20, and a systolic blood pressure of less than 90. So I saw the question that tripped everybody up was one of those surge questions. More than half the class missed it. The one that most people missed was the one that had the one about the altered mental status in it. So because they had an altered mental status and a temperature of 101, that's what made it the surge criteria. And you want to do a sepsis alert on it. Mm-hmm. So the rest of them had vital signs that were very close to being above, right? Because their respiratory rate was 20. Their systolic blood pressure was 90, which makes it tricky because it's not greater than 20 and it's not less than 90. So just keep that in mind whenever you read some of these questions. So
yeah, sepsis is a weird thing because I feel like when I went through my EMT class, I don't know about y'all, but it wasn't like that big of a deal. And then as soon as I got out of my EMT, everyone's like sepsis, sepsis, sepsis. And so it was like one of those things I had to learn as I went, but it is a very important thing and it is something that kills people. So we need to be on high alert for it. So
sepsis is something that the hospital wants to be pre-alerted about because there's certain fluids and certain medications that are supposed to be on board that patient within the first hour of them being in the ER. So if you alert them prior to being there, prior to you getting there, and they have vital signs or mentation that fits that SIRS criteria, then at that point they are getting those fluids and those medications quicker. Because if you have somebody that's extremely septic, there's actually a lot of hospitals want rapid infusion of 2 liters of fluid within like the first hour of that patient being there. Mm-hmm. So
and Levofed.
And what?
Levofed.
Yeah, and Levofed. Right. And antibiotics.
Mm-hmm. So yeah. All right. So abdominal emergencies. We have abdominal emergencies and psych emergencies tonight. They're not, both of them aren't too bad. So we're going to try and get through them. So, all right. So identify different quadrants of the abdomen and which organ correlates with that quadrant. So that should be review. Consider different field impressions of certain patient presentations. So we're going to go over different signs and symptoms that could kind of point you to one disease process or another. And then we're going to review the A&P of the abdomen. So my mind just went completely blank. So it'll come back to me. Oh, like I was saying a while ago, abdomen complaints. Abdominal complaints are hard, right? Because there's a lot of stuff going on in there. We can make our best guess, but a lot of times we don't know. A lot of times the doctors don't know until they run their little tests. But if you are on high alert for the things that are going to kill them the quickest, that's important. So you can kind of have it on your little differential diagnosis list. All right. Jade. Case number 1. Here's your patient. She's an 18-year-old female with a chief complaint of abdominal pain, nausea, and loss of appetite. During your secondary assessment, you note that she has rebound tenderness in her right lower quadrant. Her temperature is elevated, and her position of comfort is the fetal position. What is going through your mind for this patient? Okay, why? Yeah, so appendicitis, right lower quadrant, your appendix likes to hang out right there apparently. And whenever it gets mad, that's usually what starts hurting. Good job. There it is, mad appendix. So here's our quadrants. We have right upper, right lower, left upper, left lower. And then our umbilicus, or our belly button, sits right in the middle of it all. So it's divided into 4 quadrants. So what sits right up here in your right upper quadrant? The liver. What about left upper quadrant? Stomach and spleen. Okay. Right lower quadrant we just went over. What about our left lower quadrant? Intestines. Yeah. All right. So these organs, they all fit in there somehow or some way. They contain many organs that provide functions such as digestive, right? Reproductive, endocrine, and then regulatory. So it helps us keep homeostasis. It absorbs fluid, it absorbs nutrients, electrolytes. That's actually how we get most of our water intake, is through our food. Some people, I had a test question like that on my paramedic test, was like, how do you get the most intake of water? And I'm like, by drinking water, duh. No, it's by your food intake. So the peritoneum is this lining. So your organs sit in here. So it's this lining that go around your organs. So it covers the cavity and it lines each organ. And then there's 2 kind of areas. So behind, this is like the belly button up here. This is behind. This is the spine. Okay, and these are like your aorta and your vena cava. This is like cut in half looking down, if that makes sense. Does that make sense to everybody? Okay, so retroperitoneal organ. Retro, I always remember, is like throwback. It's in the back, right? So what organ do we think sits back there? The kidneys. So parietal peritoneum is attached to the abdominal wall. So that's this area right here. It's attached to the abdominal wall. And then the visceral peritoneum covers each organ. So it comes around and covers everything. Does that make sense to everybody? Okay. So most are enclosed within the parietal peritoneum. That's like the biggest space of our stomach, right? And then few lie in the extraperitoneal space, which is outside. So we're looking at like the kidneys down into like the bladder kind of stuff. So the bladder and part of the rectum lie inferior to the peritoneum. If it's inferior, what does that mean? Below. Good job. Kidneys, pancreas, and part of the aorta are in the retroperitoneal space. So it's behind that. So if we go back to this other picture, you can see it. Does that make sense to everybody? I think, who was it that was riding with me when I had a patient with a retroperitoneal bleed? Somebody was riding with me. They had a bleed back here by their little kidneys. All right. Maybe. Yeah. Yes, because you showed up. It like came out like super early. Yep, it was you. All right. Another thing that lies in our abdominal cavity is our large blood vessels, right? So our aorta comes down, our inferior vena cava, it comes down and it splits and it goes into like our iliac arteries. And whenever it splits right about the area of our belly button, and then it goes down into each leg. So lots of big veins and arteries in this area, right? So what happens whenever this artery starts to balloon out? What is that called? Yeah, abdominal aortic aneurysm. What kind of signs and symptoms are associated with that? Tearing pain. Good. What are you going to feel on your pulsing mass? Yep. And you're not going to touch it.
No touch it. Do not touch it.
Oh, okay, I'm done. And then you drive real smooth. All right. So there's different types of abdominal pain. So we use these whenever I wouldn't like explain it to my patient using these terms. But if we're calling it in, this is a good way to kind of describe each pain. So there's a visceral pain. It originates from the organs within the abdomen. So our organs don't have as many nerve endings. So this is not going to be so much of a sharp pain. It's going to be like a dull radiating pain. And they usually say intermittent pain is the hollow organs. So what's an example of a hollow organ? Stomach, yeah. And then persistent pain originates from solid organs. What's one of our solid organs? Kidneys, liver. Yep. Does that make sense to everybody? So, okay. All right, and then we have our parietal pain. So this originates from the parietal peritoneum. What is the parietal peritoneum again? It's what attaches to like our abdominal wall and covers, right? So this is where we have all our nerve endings. So this pain is going to be sharp. So if whenever we're asking our OPQRST questions, they're like, yeah, it's dull and achy, or it's sharp, it kind of gives us a mental image of what's going on in their belly, right? And usually it's localized to a specific area. Sometimes it can radiate, sometimes it can move around, but they are like, it hurts right here, and they can point it out. All right. Amanda. Case number 2. Your patient is a 62-year-old male with a chief complaint of chest pain. On your OPQRST assessment, the patient tells you that the pain is a tearing pain in his upper abdomen/chest that radiates to his back. What considerations should you have in caring for this patient?
In the chest.
Good. So we want to consider chest problems, anything inside the chest. What else? How is he describing his pain? It can be a solid organ, or what other vessels lie in this area? Yeah, a tearing aneurysm, right? So your tearing pain kind of tells you that that's one of your differentials at that point. Good job.
When you look at the like tests for National Registry, you know how we always say like this is like, like the drooling, with the kids, or the seal cough with the kids and stuff like this. This tearing pain is going to be associated with those AAAs on those tests. So if they say that they have tearing pain, that needs to be kind of in the forefront of your head, because that's what they're kind of like pushing you at. That's the common words between those.
Yep. Yep. So that's where it also, like, your assessment is really important on patients, because a lot of times you'll get called out for like chest pain or abdominal pain, and it could be one or the other. Like, I'll get called for chest pain and it's actually their upper abdomen that hurts. I'm still going to do a really good assessment, but it kind of makes a difference in my differential diagnoses. All right, so tearing pain, there's a few things that can be associated with it. Whenever we're taking tests, we're going to say that you should be thinking of a AAA or an aneurysm, but in real life, there are other things that are associated with this tearing pain. So aortic aneurysm is the one that's going to kill them the quickest, so that's what we're going to be most concerned about. Because the aorta sits in that retroperitoneal space, that's why they get that referred pain to their back. And then ulcers in the stomach can also cause like a tearing pain in the upper abdomen. So that's another thing that could be on a list, like your differentials. But is that going to kill them as quick as a AAA? Probably not. We're going to consider it, but we can't do the scans and rule everything out. All right. My dexterity's not there. Joe, case number 3. Your patient is a 36-year-old male with a chief complaint of left shoulder pain. Patient has a history of alcoholism and pancreatitis and is non-compliant with his doctor appointments. What considerations should you take in assessing this patient? Okay, so look at his past medical history. His past medical history. So he's got like pancreatitis issues, right? So whenever we're asking our OPQRST questions, we're going to really focus on the R for this case specifically. So the R, does it radiate anywhere? or is it a referred pain? We should be thinking that to ourselves, right? So let's talk about referred pain. The perception of pain in skin or muscles at distant locations. So if somebody's having some kind of like pancreatitis, anything that sits up against their diaphragm, a lot of the times it'll get referred to usually their left shoulder, sometimes their right. So another consideration in this is like your trauma patients. I've had patients with like a stomach bleed and their only complaint was their left shoulder was hurting them. But because some old medic a long time ago was like, if they have shoulder pain after a car accident and they didn't hit their shoulder, they need to go. And so we took the lady and she ended up having a bleed into her belly. So those are things that you need to consider, that if there's something going on in the stomach, it can be referred somewhere else. The left shoulder is just one example. So here's like a little diaphragm. I read diaphragm as I was trying to say diagram. So here's like common referred pain areas, right? So the bladder's kind of over the bladder and comes up. The appendix, you can have pain around your belly button. Your gallbladder or your diaphragm is in the shoulders. And then your esophagus can be like part of your stomach, but that can also be like, has to do with your heart. Your heart can be in this area. So this is kind of like a generalized things you might see. Not every patient's going to present like this, but it is good to keep in mind that pain can radiate and it does refer. Does that make sense? Okay. Nerve endings are weird. They try to talk. I don't know if you've ever like scratched your leg here and you felt it like up here in your ribs or something. Referred. So those pain sensations are transmitted from one system to another. All right, so we're going to talk about abdominal conditions. This is a cool thing I just learned about this year. They call it like Medusa's head. It's a sign of hepatic problems, so problems like with their liver. It's like hypertension of their vessels in their belly. So it can present like this. I thought it was kind of cool. It's not in your book, but I wanted to show y'all because it looks weird. Looks like little snakes. All right, so appendicitis is an infection of the appendix, right? We break down the word appendicitis. Itis meaning inflammation, and then your appendix. Your signs and symptoms, as Jade saw with our patient earlier for case number 1. Nausea, sometimes vomiting. Pain often initially referred to the umbilical region and then followed by persistent right lower quadrant pain. Another thing that should be like a trigger word in any kind of testing is rebound tenderness whenever it comes to your appendix. So if you're taking a test and it says your patient has abdominal pain with rebound tenderness in the right lower quadrant, you should have this little ding, ding, ding appendicitis going on.
Does everybody know what rebound tenderness means? Yeah.
Yes.
So the only reason why I ask is because I went through EMT school and they were like rebound tenderness. And then it wasn't until like months later that I actually figured out what that was. So what rebound tenderness means, if I take little Beckaboo right here and I'm checking her abdomen, right, and I push in right here, when I let go real fast, and she's like, ow, that freaking hurt. That's what rebound tenderness is. It's not when you push in, it's whenever you let go real fast or just let go. That's when the pain starts. Ask them that. They're like, hey, did it hurt when I push in or did it hurt when I let go? And that's what rebound tenderness is.
Mm-hmm. Thank you. All right, so appendicitis can lead to a rupture of the appendix, and that becomes a problem. Why? Sepsis, yeah. So all them juices that accumulated in the appendix are now everywhere in their belly. So sudden severe increase in pain. I'm actually going to say most patients that I've seen with ruptured appendix have had like really, really bad pain. Then it got really, really bad, and then it just stopped hurting. And that's when it ruptured. But per your textbook, sudden severe increase in pain. And then those contents are released. And then it becomes a real big problem. Can lead to peritonitis. So peritoneum is the lining that lines your organs. Peritonitis is inflammation of that. So whenever something like your appendix ruptures or you have some kind of penetrating injury, diverticulitis, where something like there's some foreign body introduced into your abdominal quadrants, it can cause this. So it's irritation, usually caused by foreign material. This causes involuntary contraction of abdominal muscles. So sometimes whenever you're feeling their belly and seeing how like where it hurts, it'll feel hard because they're trying to guard. Those muscles are tightening up. So like if someone goes to punch you in the stomach, you're going to try and flex, right? Because you know it's going to hurt. So this is kind of what they're doing. They're like, oh, it hurts.
No,
They're trying to protect that area.
Mm,
And then here's just
got
another picture of what it looks like. It's all
Appreciate it.
inflamed in there. It's a small picture. I apologize. All right, case number 4. Emily's down in Austin, isn't she? Erin. Your patient is a 42-year-old male with a chief complaint of abdominal pain. Patient reports that the patient is worse at night, or the pain is worse at night while he is laying down. Patient also reports increased pain after eating his hamburgers. What is your suspected differential diagnosis and what other systems would you assess? There's his hamburger.
That hamburger was delightful.
Yeah.
I would think maybe he had it blocked in
Okay, like where?
probably like in block of pain,
Okay.
just from the mass amount of gross, I mean, delicious looking food that he
Frick yeah.
Good. Okay, so there's something very specific about this case that leads you to a certain differential diagnosis. When he's laying down and that it's worse at night. So what could that be indicative of? Does anybody have an idea? Gallbladder. Yep, good. He's eating because they lay down and those stones roll around, cause more problems. If anybody wants to know like weird fact about Becca, I really want just a jar of gallstones that I can put on my wall because they look so cool.
We have a morbid wall at house. We're not just putting them in random places. We have like a whole like bookshelf full of really weird things at our house.
Morbid things, yeah.
Yeah.
We got like bullets from people we pulled from Atlanta and stuff. It's cool. All right, so cholecystitis, the day we did our medical terminology slideshow, we broke down cholecystitis, right? So if anybody remembers, does anybody remember what it means? So itis is inflammation of. Chole is the sac, and then the cholecyst is like the sac of bile. So inflammation of the sac of bile, which is our gallbladder. So cholecystitis, gallbladder problems, or gallstones. So whenever people eat like really fatty meals, they can get a buildup of these gallstones. And one of the signs and symptoms is like pain that it gets worse at night or whenever they lay down. Usually it's right upper quadrant pain. It's like right in this area, right? And the pain can be referred to the shoulder because it's sitting right up against that diaphragm. So if anyone's wondering, these ones are my favorite. It looks like corn pops. I want a jar of them. I've like went as far as asking patients that I knew that had them when I was like transporting them for surgery. Like, if you can get a hold of those, here's my number. Never gotten them though. Yeah, yeah, it's fine. All right, so GI bleeds. So gastrointestinal bleeding. We refer to it as GI bleed because nobody wants to walk around pronouncing gastrointestinal all the time. So bleeding within the GI tract. That can be anywhere from up high to down low. So we're going to see different kinds of blood or like signs of blood and bleeding depending on where that bleeding is coming from. Can be minor to severe. I will say out of all the medical patients, not trauma patients, that have coded right in front of my eyes, like 3 out of 4 of them have been GI bleeds. These patients are sick or they have the potential to be very sick. So that bleeding can be going on for a while, but then it eventually has to come out, right? So it can either come out in their poo or they can throw it up. Usually it's painless, can be caused by gastric ulcers. Does anybody have like an idea of what color that blood's going to be if it's been sitting in like upper for a while? Yeah, coffee grounds emesis. All right, what if it's like really high up in the GI and it's caused from like excessive vomiting? What color is that going to be? It's fresh blood. Bright red. Yep. And what about if they're pooping and it's been sitting in there a while? What color is it going to be? Black. Yeah, it's like a black tarry stool. And then if it looks like grape jelly or jelly at all and it's like bright red, that's kind of closer, right? And then you can have like bright red blood at the rectum. That's usually like your hemorrhoids. So it's always good to ask your patients if they're like, yeah, I threw up blood or I pooped blood. Can I see it? Do you have it? Because it kind of tells you what's going on. I don't ask to look at everyone's poop, but sometimes I do. So here's some examples. Here's that black tarry stool that we were talking about. And then the stool that's more like a bright red color. This is that coffee ground emesis. So emesis meaning puke, right? So coffee ground vomit. And then bright red vomit. If you walk in and see this, it's a bad day for everybody. Usually this is caused by, what's the name of that tear? Mallory Weiss tear. So pregnant women that are like vomiting a lot because of like morning sickness or like constant vomiting, you can actually tear part of your esophagus and start puking up bright red blood like this. Or there's another condition called esophageal varices that can cause that. And both of them need to be seen right away, obviously.
Jade learned what that was the other day.
She did. She
There
sure
was a
did.
lot of blood in the back of an ambulance. There's a very distinct smell with these GI bleeds that you will, once you get it once, you'll never forget it. And every time you walk in the house, you'll know exactly what it is whenever you walk in the house. It's kind of like UTIs. Once you smell one UTI, you'll never forget that smell, and you'll know it as soon as you walk in somebody's house. It is a strong iron poop smell.
It's like someone took chicken livers, sat them out in the sun for like a week, then threw them in a hot dumpster, and then boiled them for a second. That's kind of what it smells like. That's the
It
best
is a
description.
very distinct smell, though, and you will know it real quick.
Yeah, we can bring some in. No, it's gross.
If you do that, let me know, because I'll use those chicken livers for catfish.
All right, so here's our triple A's. We've talked about these a little bit, so this should be a review. So ballooning or weakening of the inner wall of the aorta. So our aortic walls are made up of 3 different layers. So whenever that inner layer gets torn and that blood starts to pool in between those layers, it starts to balloon out and it looks like this. And then it can rupture. So if it ruptures, they basically need to be on a surgical table as it's rupturing. But those are things to keep in mind. Not very good. There's some people that walk around with like aneurysms that don't even know that they have them. And then they die and they do an autopsy and they're like, oh, they had a little aneurysm. They don't even know. But whenever it gets big and they start losing a lot of blood or it starts pushing on things it shouldn't be pushing on, that's whenever we get called. So your signs and symptoms: progressive, sharp or tearing abdominal pain. Keep in mind that this is specifically towards the abdominal aortic aneurysm, so that big one that sits here. Other arteries can have these happen to them. So I've had them where there's like an iliac artery doing this. So it's different signs and symptoms. So like one leg was like completely pale, cold to the touch, no pulse, and the other one was fine. So just these are specific to the abdominal aortic aneurysms. So frequently radiates to the back. Does anybody remember why it radiates to the back, the pain? Yes. Yep, because your aorta sits in that retroperitoneal space. Signs of shock, obviously. What kind of shock would it be? Close. I like where you're going because you're like, walls of the aorta. Not quite. Mm-mm. They're bleeding out into their belly. Hypovolemic. Good job. Another big thing that's going to probably be on a test, if it's not ours, it's most likely going to be the National Registry or a future test. You guys do the test prep, you might already have seen it. these unequal pulses or blood pressure. So that's why we have you do pulses on both sides at the same time. And then blood pressure, you can take one blood pressure on one arm and do the other side, and they're going to be like vastly different. And that's also indicative of something like this.
So you would do that if you suspected this, just kind of roll it out.
Yeah. Yeah. And honestly, I have the AAAs that I've seen, I've only seen like 4 of them in my career, and only like 1 of them had unequal pulses. So they love to teach it, and yes, look for it, but it's not like
A
the most
super
common thing that you're going to see. If you are suspecting it, absolutely do one on both sides. So here's those layers that we were talking about. There's this inner layer, the middle layer, and then the outer layer of these walls. The inner layer gets some kind of disruption, and that blood starts to pool in between those layers, and then that's why it bubbles out. Does that make sense to everybody? All right, case number 5. Who's gonna keep him alive? Scott's gone, isn't he?
Yeah, Scott's out there saving the trees.
He's out there saving Annie. Your patient is a 20-year-old male that has called the EM. Let me start over. Your patient is a 20-year-old male that called EMS from the gym. Patient reports that he does a lot of heavy lifting and has a bump on his belly. He has ignored it until today when it started changing colors and now hurts. He reports that he used to be able to push it back in, but now he can't. That's what it looks like. Mm-hmm. Good.
Because he was able to push it back in and now he can't.
Mm-hmm. What? That's okay.
It's surgery time.
Yeah, it is surgery time. That's good. So she said it's a hernia. The fact that he used to be able to push it back in and now he can't, that is a sign of, she can't remember the name, but strangulation. And it's now surgery time. Good. So hernias, they can pop up anywhere. You can see these. So they call them like inguinal hernias, femoral, umbilical, epigastric, just depending on where they're at. So what happens is that layer of muscle in the abdominal wall weakens and their intestines start to come out. Or other parts of organs, usually the intestines. Usually may be precipitated by heavy lifting. And the problem is once they get out, if there's any kind of like twisting motion or any kind of blockage of blood, it gets strangulated. And it usually your signs and symptoms are they can't push it back in anymore. And yes, it is now surgery time if that happens. Another thing it can cause is a bowel obstruction. So whenever we're talking about like bowel obstructions, that's another thing to keep on your list of differentials. When's the last time you pooped? Have you been puking every day? Those kinds of things are good to ask. Renal colic, so pain referred to like the renal system. What's our renal system? Yeah, your urinary, so your kidneys, your ureters, your bladder. Severe flank pain caused by kidney stones traveling down the ureter. So the majority of the time when those kidney stones are sitting in the kidneys, they're not going to have any pain. But the second that they try to come out, if anyone in this room has ever had kidney stones, I personally have not. I've heard that it's worse than childbirth. So there's that. This is why, that's what they look like. They're not smooth, and you're trying to move them out this little tiny, ouch. So severe pain in the flank or back, so back here over the kidneys. You can do an assessment by tapping, and if you tap, it's usually like, that's what they do. And then it can radiate to their groin as well. So difficulty urinating, yeah, nausea, vomiting. I've seen like grown men are like in the fetal position, diaphoretic, rocking back and forth. And I'm like, they're dying. And we get them to the ER and they're like, yep, kidney stone. So kidney stones hurt. They suck. So like Amanda said earlier, anytime there's something involved like in this area, We also really want to have a high index of suspicion. I love that word. You guys have probably learned that by now, of cardiac issues. So women, diabetic patients, older patients, very commonly don't present with the common chest pain that radiates to the left arm or my jaw. So keep this in mind. Any kind of indigestion, stomach ache, those kind of things, we should be trying to rule out cardiac issues. What's epigastric pain? It's like heartburn. It's like in this area, epigastric pain. All right, we talked about this whenever we were doing our Cahoots the other day. So female reproductive system considerations. Any female within childbearing age with abdominal pain is an ectopic pregnancy until proven otherwise. Why do we say that? We can't rule it out, and it can kill them quickly, very quickly. So you'll learn that in medicine and EMS is they teach you the things that are going to kill them the quickest, and usually that's like the first thing that you need to consider. Like, oh crap, it could be this. We have to rule it out. So what happens is the fertilized egg does not get where it should be going, so the uterus, and it usually lodges in this fallopian tube, and then once it starts to grow, it'll rupture, and there's a lot of internal bleeding that goes on. I used to think like, oh, they'll have like vaginal bleeding too. That's not the case. So don't be like, oh, they don't have vaginal bleeding. It's not an ectopic pregnancy. That's not the case. So life-threatening internal bleeding. That's why internal is underlined, because I want you guys to keep that in mind. And then some ways you can kind of rule this out: ask about their last period, ask about possibility of pregnancy, and then you can ask for any abnormal bleeding or discharge or anything like that. So your assessment and treatment, obviously, whenever we palpate, we start at the most hurty part first, right? No, thank you. I saw two people shake their head yes, and I almost threw a popsicle stick at them. No, we don't. Why? Yeah, they won't want you to touch them anymore. Protect yourself from vomiting. That's every patient, but especially abdominal pain patients. Transport in a position of comfort. If they're in shock, we're going to treat for shock. But if they're able to like sit up, what's usually the most common position of comfort for these patients? The fetal position, or their knees pulled up, because it takes that strain off of their belly. Geriatric, what does that mean? Elderly, yeah. I used to have a hard time. Geriatric and bariatric were the same in my head for a long time. So the older population, yep. So as we get older, our ability to perceive pain lessens. Our little nerve endings start to die out. So keep that in mind whenever you're doing these assessments. They have a decreased ability to perceive the pain, and then it also might be complicated by medications. So that also might, their medications that they're on also might cover up a lot of stuff. And that's it. Does anybody have questions about abdominal emergencies? No. Okay, go ahead and take a 5-minute break. Oh, gallstones. Yeah, good job. I Googled butterflies and rainbows, and this was the first picture that popped up. So that's what we get. Yeah. Yeah, the other slides are depressing, but this one's not. Exactly. It's fine. Yeah, this chapter, I'm like, oof, it's kind of a tough one to get through. It is heavy. And it sucks because like you walk in there like expecting to fix them because we're fixers, right? We want to fix them, and there's most of the time we don't do anything. So yeah, I don't think this one's too long though. Yeah, it's only 22 slides. No, you're fine. There you go.
If you put them out, yeah. So they're secure too. It was like guys going crazy. You sit there with my foot. You step back and you went long for it. No.
Who's all done ride-alongs? Who's had the coolest shit? You gotta go. Jade had some shit, dude. Jade had some shit on her ride-along. Got to watch a lady get innovated, blow a turbo. Jade got to say some shit. Sushi.
That's dramatic, fucking crazy.
Yeah, we got some shit. Yeah. Love being.
They're all doing it. Yeah. This is the chapter about the people I have.
I like
This
fishing.
conference will now be recorded.
All right. We're going to get through this PowerPoint real quick, and then we're going to be done. If we get done early tonight, which is a good possibility, and anyone wants to stay and go over scenarios, you are more than welcome to. I'm cool with hanging out for a while, so
A little
up to
while,
y'all.
though. I want a snack.
A little while. Like, if you hang out till midnight, you'll have to hang out with AD and Hannah, but we'll be here. So, behavioral and psychiatric, I've heard, as from the class, this was a very sad chapter to try and read. It is. I will say it sucks because we walk in wanting to fix these people and help them, and a lot of the times doesn't happen.
There was a question that said, how would you secure a patient that's going wild?
Yeah.
And I had like secure 2 limbs, lay them down,
Mm-hmm.
and like the other 2 I don't remember. If they're attacking me, I'm just saying.
Mm-hmm.
So what you got to understand when it comes to these psych patients is one of the biggest issues, and you can look it up because I love news articles for this reason, is they tell you what's going on. And right now, one of the biggest issues that we have in EMS is assaults on providers. And it's because people are not prepared for this. A lot of them are psych patients. A lot of them honestly don't even know what's going on. They're schizophrenic, they're bipolar, they're on drugs, whatever the case is, right? But that's one of the biggest things that we have in EMS right now is assaults on providers. So when you go in and deal with these behavioral patients and these psych patients, please watch what you're doing. Don't get within arm's reach of these people until you have to. And I say that respectfully, right? Because I don't want you to get dog piss beat out of you. Like, you got some people in the class, that, like Mr. Lake back here that probably beat dog piss out of them. And then you got some of them like Alyssa and Amanda that's a little bit smaller. And you go up against a 260-pound, you go up against a 260-pound grown man. So when me and Becca were going through paramedic school, we had a discussion. And we said, when we finish paramedic school, what's one thing that we're going to butt heads about? And it was psych patients. Because I will absolutely wholeheartedly, I'm not fighting you. I'm 35 years old. I got back issues. I got knee issues. Like, I'm not about to fight you. I got drugs. You about to take a nap. I'm just going to be completely honest. Like, I'm not going to do it. And when me and Becca first finished paramedic school, that is the one call that we argued over was psych patients. And I told her, I said, listen, you're going to be back in the back of this ambulance one day and you're going to get dog piss beat out of you. and you're going to wish you had sedated somebody. Now, she'll sedate folks because her and her old partner at Grady, her old partner at Grady went about 10 rounds with a psych patient in the back of an ambulance that broke
I was
needles.
trying to sedate him.
She was trying to sedate him.
He did bend needles. It was
He was
terrible.
bending needles. He was fighting. And now she doesn't have a very high tolerance for it either. She will sedate somebody fairly quickly. So please
Well,
be careful with these patients.
yeah. Chaz and I got split up, and I was running a car accident with an altered guy that was fighting me, and I was like, I'll be able to talk him down. And I'm sitting back there by myself. It's like this really tall, like, dude. And he grabs me by my shirt and like pulls me, and I was like, I should have sedated. So I'm
So I
still
say
here to
that
tell the-
respectfully because a 260-pound grown man gets you in the back of that closet, especially if you're a smaller individual. You know, just
It takes like, I've seen like even smaller people, like little tiny, I use the word crackhead as an endearing term. Little tiny crackheads that it takes like 6 people to hold down because they just get like this extra strength. I don't know where they muster it. Yes, I don't know where they get it from, but they pull it out of somewhere, and everybody's trying to hold them down. So, yeah.
lucky for us, we have a sheriff's department that responds to all of our medical calls with us,
Yes.
or at least 98% of our medical calls. So if we have to go rounds, we do have some pretty rowdy guys on our sheriff's department that will go rounds with you.
Mm-hmm.
Unfortunately, not everybody's like that. You get to some of these places, and the sheriff's department will sit there and watch you get your freaking teeth kicked in the back of an ambulance. Trust me, I've been there. They will stand in the back of a truck and watch you fight a patient in the back of that ambulance. So
It's true. All right. No longer fun. All right, so our objectives for this chapter, we're going to define a behavioral emergency, identify special considerations in psych or behavioral patients' calls, identify what vitals are associated with excited delirium. So whenever we get on these calls, excited delirium, they don't like using that term anymore, but that's how everybody still refers to it. It's like a behavioral psychosis or drug-induced psychosis. It's excited delirium. But people are like, it's offensive, so don't use it. I don't know how it's offensive. Every time I've ever used those words, I've never had someone be like, that's offensive. That's not what it is. They know exactly what I'm talking about. So, all right. So what is a behavioral emergency? So let's first define behavior. It's the manner in which a person acts or performs. So behavioral emergency, within a given situation that is unacceptable or intolerable to the patient, patient's family, or community. So our kind of deciding factor on the ambulance whenever it comes to like safety, that's the big thing. Is this person a danger to themselves? Are they a danger to other people? And that's where we usually come in. Naked dude running down the road.
you will fight naked people. They love
like
to fight
run,
you.
and they love to run down the road for some reason. So some considerations, recognize cultural behavior. If you're in a city or a certain area where there is like certain cultural differences, make sure that you are familiar with them. In Atlanta, we dealt with like a good subset of people that it was their religion that men couldn't touch them or assess them. And so if a man was trying to assess them or touch them, you could have perceived it like this is a behavioral emergency, but that's not what it was. It was a cultural. There's some
Well,
places.
and some of them don't have. Some of them have like language barriers.
Yeah.
And so you'll run into that too, where you're trying to like do stuff, and they're like freaking. You're like, why are you fighting me? And it's because of that, but because of the language issues, you won't know what's going on.
Mm-hmm. And we also couldn't like draw blood from these people. So if you were like trying to get a blood sugar, and they were like, that's why. Behavioral conditions require full patient assessment. Why? Why is that important?
To make sure they're not altered for different reasons.
Yes, exactly. So if it has came down to altered mental status, there's 100 other things that can cause altered mental status. This is just a small list. So that is also important. and then remain objective. So whenever you walk up on scene and you have sheriff's office telling you one story and the patient's like, these aliens came down and they tried to attack me, blah, 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 blah. And the sheriff's office is like, yeah, we showed up and he was just sitting here and he looks like he ran a marathon, but he hasn't ran at all. Take all of those things into consideration. Aaron just answered this for us. Here's a list of things that may cause altered mental status, right? We went over it with our neurologic section. So we want to keep these things in mind. If they are altered, why are they altered? We want to do our full assessment. We want to check what we can check. Our toolbox is only this big. We might as well use our tools, right? Yes, there are times that you are fighting someone so bad you're not going to get a blood sugar. That's okay. Read the room. If they're trying to punch you in the face, try not to stab them in the finger. It's kind of how that goes. Here's a video of hypoxia in action. So what they ended up doing, this is a pilot. We don't have to watch the whole video. I think it's like 7 minutes long, but you'll get it in the first little bit. There's some lady talking and it's like distorted. Drives me nuts, so I apologize right now. So what they're doing is this pilot, they are taking the oxygen out of the room and they're asking him to hold up cards and read the cards and show the camera and say what the card is, like playing cards.
And as you commit yourselves to it, let us know where they are. Six of spades. No, this isn't a check. 2 of hearts. 2 of hearts. What's the last card? Four spades. He's not going to judge right now.
I don't know why that lady was chatting.
Yeah.
Yeah. See how he's getting slower? And he's kind of got like this dazed eye look. It's not a 4 of spades.
4 of spades. 4 of spades.
He's trying.
Our hero.
There he is.
So the reason why I like this video is y'all know I like pulling up news stories and talking about how people get sued and how people get charged with stuff. There was an incident that happened last year in New York with a couple of EMTs that showed up on scene. There was a male patient that was fighting them. And they were like, frick you, man, get out of our truck, and kicked him out of the back of the ambulance.
There's like body cam footage of them being like, get out of our truck.
Yeah. Understand, if the sheriff's department's there, you were on body cameras. So if you do something stupid, well, that's between you and the Lord. They were actively like, get out of our truck. We're not doing this. Like yelling at this guy, cussing at this guy. He ended up going into cardiac arrest right after they kicked him out of the truck.
They found him like dead on a bench somewhere.
So
he had called for difficulty breathing. So why do you think he was fighting them?
Hypoxia can make you altered. So keep that in mind.
Yeah, and that's a nice hypoxic patient. So that's his reaction to hypoxia. But imagine that for a prolonged period of time. They're not always that nice. They're confused. Yeah.
Especially if they know what's going on, right? Like if they know that they're having difficulty breathing, they're starting to experience this hypoxia, they start getting altered, they're anxious, right? Because anxiety is a big issue whenever you start having severe difficulty breathing, right? And so they're already in a heightened sense of distress, and then they start getting hypoxic, altered. Some of my best fights have been diabetic patients.
It's true.
So make sure you check everything. Don't just assume that these patients are just crazy. You have not been doing this long enough to walk into somebody's house and say, oh, they're just having anxiety. right? You need to check all of your bases. Whenever you get 20 years under your belt and 10,000 patients, and you know how to assess folks, if that's going to be your differential diagnosis, and that's fine. Until then, you need to make sure you go and assess these folks very, very thoroughly.
Mm-hmm. Yep. All right. So behavior and brain chemistry. I'm not going to do any of this justice, and I'm going to say this looking at Calvin sitting back there. So observable behavior largely controlled by neurotransmitters inside the brain. Neurotransmitters travel from neuron to neuron, and then those impulses move across by this mechanism. Okay. So brain chemistry. A lot of times, if there's a mess up in the brain chemistry, that's where like our behavioral comes in. So depression, schizophrenia, anxiety, all that fun stuff. Hopefully I said that right. Calvin's not having an aneurysm back there, so we're good. All right, so neurotransmitters or lack thereof have been connected in depression and others. Okay, thank you. I figured you're gonna have something. If you guys ever want to learn about the brain, that's the guy, because he makes me feel stupid every day, and I love it. I always learn something new. All right, psychiatric conditions. I always did think it was weird because you bring someone in there like, I have schizophrenia, and they're like, yeah, it's an imbalance of chemicals in the brain, but they never do any kind of testing for.
I have my own theory about schizophrenia, but
yeah,
we'll go over that in somebody else's free time if you don't know.
yeah. All right. So some behavioral emergencies are caused by psychiatric conditions or mental disorders. 1 in 5 adults have some sort of mental illness. So what? There's 22 people in here right now. So 1 in 5 of us, 4 of us are crazy a little bit. So
I'm one of them. Okay, I'll just go ahead and check one
there's
person off the list.
possibly more because to get in this line of work, you kind of have to have a little bit. So
I got paperwork. So
yeah. So the thing about our mental health system in this country is it sucks. So you see it firsthand. You deal with these patients that are suicidal, depressed, whatever you got going on. You take them to a mental health facility and they're like, there's nothing acutely wrong with this patient. See you later. And they kick them right back out. So our instances in EMS go up a lot higher because stuff like this.
and they do. We used to watch it all the time in Atlanta. We'd go drop a patient off that was like suicidal, and then show back up 30 minutes later and they were walking down the road. So our mental health system is atrocious.
Yeah. Like you had to convince them over there that there was something majorly wrong with that patient. Like I went as far as taking his phone because he had taken a selfie of a gun to his head, and I was like, please treat this guy because he had been kicked out like a few hours before.
Yep.
All right, so situational stress reactions, normal reactions produce emotions. Obviously, we are all familiar with this. We're adults in this room. So fear, grief, anger, that all happens. And then we can care for patients with situational stress reactions. Not only our patients, but also our patient's family. So like the other day, we ran a cardiac arrest. Shortly thereafter, the family tried verbalizing that he wanted to kill us. That was probably a situational stress reaction, right? I've had that a lot where the family members get all hyped up and they got a lot of stuff going on. I've ran calls with like deceased people and the person who felt like it was their fault that person was deceased. Now I'm treating them as a patient because of this stress reaction. So keep that in mind. That kind of goes into like your scene safety because we don't know how people are going to react to things. Don't rush them. It's hard to be in this line of work at 2 a.m. and you want to go get back in bed and you're like, all right, come on. So we talked about earlier, a few classes back, that whenever we're asking patients questions, you actually want to sit down and listen to their story. Like that means a lot to somebody. It takes an extra 2 minutes out of your time just to listen to them. Remain calm unless they're actively punching you in the face. We don't want to escalate a situation. So this PowerPoint and this whole section of your book, there are hours-long classes taught on how to de-escalate situations, how to deal with somebody that's like all hyped up and angry at you. So if you ever like want to read more into that, I highly suggest it because it can actually really help a situation. I've been in a lot of situations where I'm trying to calm the patient and not him, but I've had partners before walk up and just like escalate a situation, and it's a completely different patient at that point. So that's my spiel. All right. Acute psychosis. This is a severe break in patients' abilities to process information and interact with their environments. So their brain is telling them one thing, and it's not matching up with what's going on in real life. So this was like a good picture of what I could depict of it, like their life's falling apart, and to you, it's just another normal 72-degree day. Usually associated with a psychiatric disorder as like schizophrenia or bipolar. I believe this falls down into like your manic episodes is a form of acute psychosis. So these patients can be kind of in a different realm. Hallucinations, delusions. What's catatonia? Yeah, they're catatonic. Yeah, lights on, nobody's home, like psych episode. And thought disorder. So their thoughts are not in one line. It's just all over the place, kind of thing. Hopefully,
These folks may be hyperverbal. That does not mean that they're aggressive. Let them sit there and chat. A big reason why I didn't ever go back to Elko County and work is because when I was doing my ride-alongs there to be a paramedic up there, I had somebody tell me that I should have sedated a patient because they were talking too much. Essentially is what they told me. This lady was having a psychiatric episode. She wasn't hurting nobody. She wasn't doing anything. She was just like, "Burr, burr, 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 burr," and I was sitting there the whole time. Yeah, absolutely. Just let them talk. You know, they're not hurting you. And I have a pretty low threshold for sedation, and I didn't sedate that lady. So
yeah, he told me that story, and I was like, yeah, she didn't need sedated.
yeah, if I didn't sedate her, she didn't need to be sedated.
Yeah. So like we were talking about, there's a whole range of presentations when it comes to acute psychosis. Withdrawn, not communicating at all. Don't like try and pry a little bit, but don't just overwhelm them like by asking them questions, forcing them to do assessments that they don't want to do. If you're trying to like do a good assessment on them and you can't, make sure that you're charting that. Like assessment was attempted, patient verbalized, don't touch me, whatever. So make sure you're charting why you're not doing a full assessment if there's ever a reason you're not. Bizarre or threatening behavior. Chaz has had people yell at him and say, someone should shoot you in the effing head. Psych. Wish to harm themselves or others. So that's another question we usually want to ask, like suicidal patients, homicidal patients. That's any kind of like psychosis. Like, are you having thoughts of hurting yourself? Are you having thoughts of hurting somebody else? Make sure you say, hey, I'm Becca. I'm with the paramedics. A lot of times we look like police officers, and not everybody likes police officers. So that's another thing. Not so much around here, more in Atlanta. In Atlanta, they were huge about like hating police. So we had to be like, we're not the police.
Many, many times. Be like, I am not a police officer. They'd be like, oh, okay.
Yeah. The make eye contact thing here or there. Sometimes that makes people more aggressive. Read the room. And then don't enter their personal space. Chaz talked about that. The closer you are to them, if they do end up switching, you're closer to them. So be mindful. Suicide, the 10th leading cause of death in the United States. If they are unsuccessful, obviously there can be like physical deformities that happen. They can have some things like chemically wrong with them at that point because they tried to overdose, and now they have like lifelong disorders because they messed up their cardiovascular system. So those are things to keep in mind whenever you're treating a patient with like some kind of suicidal thought. Have they tried before? It kind of gives you an idea of what their mindset is. Yep. Veterans, senior citizen populations, as people get older, they kind of are like, well, what's the point of life anymore? All my friends are dead. So it's very common in those populations, which we talked about in our lifespan development chapter. So with our actually attempted suicide patients. We want to try and get a good history. If they want to talk about it, try and talk to them about it. They're not always going to answer you. Like, hey, you've had a lot of stressors lately. They're like, I don't want to talk about it. Okay, I'm not going to pry. But you can try and get like a good general understanding of what's going on. So ages 15 through 25, and then 40 plus is your highest risk. So 15, 25, there's a lot of things going on in brains. They're still developing. If anyone's ever been a teenager, we all have. We know that feeling of like, okay, you get all the stress of like trying to be the coolest or whatever. And then 40 plus, that thing where like midlife crisis comes in, all my friends are dead comes in. And then drug and alcohol abuse. So any kind of alcohol is a depressant, right? So depression, depressant, yeah.
I will say that of all the suicides that I have ran, and me and Mike talked about this the other day, of all the active like suicides that I have ran, I would say that almost every one of them have been intoxicated. So that is a very bad depressant, and it alters your mind. If you are a severe alcoholic, it will alter your mind and make you do unreasonable things. So if you're ever dealing with somebody that may be intoxicated and talking about being suicidal, take them seriously, because that is what the majority of my suicides have been, is intoxicated people.
Yeah. It's true. And alcohol is a coping mechanism too, right? So that can kind of be like your precursor, like someone's, really struggling, and then they just drink more and more and more, and then they get more and more depressed, and then it's never ending cycle. So some questions you want to ask or try and ask if you are able to in the moment. Do they have a plan? If so, what is their plan? So you can kind of set up like a safety plan for them. Any previous attempts or threats, we talked about that. And then was there a sudden improvement from depression? Why do we think that's important? Yeah, they decided to do it. They're like, okay, this is it. I'm going to be gone. So I got to make up. I got to go get lunch with my mom. I got to give this person their birthday present. They make a list of things they got to do before they go. And usually, if you hear people talk like, oh yeah, I've never even saw it coming. They were so happy. They were happy before it happened because they were trying not to let everybody know that it was coming, because they were trying to make tie those loose ends up. Horrible. Okay, so body language, that's a huge thing. That could also be like another 8-hour class at least. There's a few books out there. There's one called What Every Body is Saying by Joe Navarro. He was actually like trained in the CIA to identify body language. And it's actually really cool reading that book because he tells you like subtle clues that you wouldn't think to think of. Everyone like pictures a great mad person and they picture this picture. But he goes into like how their noses flare and like watching their necks and everything else. It's kind of interesting. So if you can kind of like practice this with your patients, and like you'll start to see like little subtle clues and signs. And it can protect you in the long run, right? So like if I'm sitting in a chair laid back like this chatting with you, am I going to jump up and attack you like this? Probably not, because it's going to take a lot more effort for me to get up. Now if I'm sitting there like this ready to attack you, that's a different thing, right? So gather clues from the scene. If you walked in and their scenes just tore up and they were throwing things, keep that in consideration. We talked about the different information from different people, SO, family, bystanders, neighbors, anybody. Make sure you have an escape route. Once you start doing this, it bleeds into every aspect of your life. I can't go out to eat with this guy without him being able to look at the exit door. So that kind of, he's like, we just know, like we walk in, he sits there and I sit here because of that. I've told you guys before, when I walk into scenes where like the dispatch notes were questionable, I'll lock the deadbolt, like to leave the door open. Does that make sense? So it like comes out and then I'll like let the door shut on it. so I can just push the door open. Always have a way out. So as you're treating a patient, you know I have an exit here and here. Obviously, do not threaten the patient. We're not into that here. And then stay alert for weapons. So I think one of my old instructors in Idaho, he got shot in the chest on a diabetic call. He walked in, this guy was sitting in a recliner. He was hypoglycemic. He walked in, was getting ready to do an assessment, got all close to him, went to do a pulse, and the guy pulled the gun out from the inside of the chair and shot him right here in the chest. So stay alert for those kinds of things. Obviously, we can't predict every situation, but your little spidey senses are real, and let them tell you.
Well, that's, back where we come from in Gwinnett County, Georgia, they had like 6 firefighters get held hostage by a guy who called in and said he was having chest pain. They all showed up and he flipped the covers back and pulled out a couple of guns and told them they weren't allowed to leave. So just be mindful of stuff like that, right? Like, whenever you're walking into folks' house, I'm not telling you to be scared of every patient, but just keep it in the back of your head. You never really know what's going to happen. So we're walking into strangers' houses.
Mm-hmm. All right, so reasonable force. This is one of those things. Sometimes, yes, we do need to use reasonable force. Big emphasis on the reasonable part of the reasonable force. So it needs to be reasonable. So determined by patient size and strength. That's a funny thing to put in there because I've had people like half my size beat the crap out of me. So, but that's one of the determining factors. Their type of behavior. Are they threatening you? Are they is their body language? Are they pointing at you, like threatening to hit you? Are they taking off their glasses and saying it's about to get rowdy? Like those kinds of things. Mental status. Are they just so out of it that you're going to, is there a possibility that they're going to fight you? The restraint side of this, make sure you're reading your local protocols. Like in Georgia, we had to notify our supervision and PD anytime that we were getting ready to restrain somebody. Whether they showed up or not was a different thing, but we at least had to get on the radio and say, we're attempting to restrain this patient. So read your protocols around here. My justification is if they're a harm to themselves or me, then they're going to get sedated or restrained. As an EMT, you can restrain them, and we're going to talk about forms of restraint and how often you should monitor those patients, because like Chaz was saying a few weeks ago, maybe last week, whenever you restrain somebody and you don't monitor them on the way to the hospital and they die, you look real stupid. So
real stupid. And there was a question that somebody presented to me the other day of whether you're allowed to defend yourself. You're perfectly within your rights as a provider to use whatever reasonable force is necessary to defend yourself. Mm-hmm. So understand that just because you're in healthcare, you're not just going to sit there and take the freaking skibbity pip paps to the face. Defend yourself. Don't get out here and get beat up by a patient. Like I said, the sheriff's department's with us 90% of the time. But defend yourself.
I've been on calls where my partner chokes somebody out until they were unconscious so we could get them restrained because they were fighting us so bad. Sometimes you got to do what you got to do. Reasonable force.
Reasonable force.
All right, so restraints. If the patient is a danger to themselves or others, restrain them. Whenever you restrain them, option number 1, face down. Please don't do that. Option number 2,
do not do that.
Hog tie. Please God, don't do that. Option number 3, one arm up above their head. Go ahead. I love this restraint method. Because what it does is they can't physically sit up to headbutt you because one arm's up. So I love this. One thing to be considered of, really freaky, strong, super altered people, there is a possibility that they hurt their shoulder, pop it out by doing that. That sucks. But Like if they're actively fighting me, I try to get one arm up and one arm down, and then both legs. So make sure you have a person for each limb. That's your most ideal, like if you're going to restrain somebody. And if you have SO or any kind of law enforcement on scene, utilize them. Because like Chaz was saying, around here, we have a lot of help and we really appreciate it.
You know, I like news stories and people doing stupid stuff. This face down method got a paramedic with a fat lawsuit and charges brought against her because she killed the crap out of somebody by doing this. It was on the news probably 4 or 5 years ago. So don't do that.
Mm-hmm.
Don't do that.
Yeah.
They can't breathe.
They can't breathe. It's true. Also, it makes monitoring more difficult, right? Because you're trying to monitor somebody, say that they're in like an excited delirium state, which we'll get to, and you have them face down, and you're trying to like listen to lung sound. Sure, you can listen to them on the back, but they might go unconscious, and it might be more difficult to the forelead, not as effective on somebody that's face down. You want to do vital sign assessment every 5 minutes. If you can do it less than that, that's fine too. But you should be assessing these patients frequently after you restrain them because of the excited delirium, which we'll get into. So, excited delirium, extremely agitated or psychotic behavior. So these are the patients that my experience with excited delirium patients, it's caused by a drug intoxication most of the time. So they take a bunch of uppers. My like little thought process is like as soon as I take their temperature and it's high, like associated with all the other vitals, I'm like, oh, this is excited delirium. So usually they're like running around fighting everybody, and then you restrain them, and then all of a sudden they just die. So that is always a possibility. So the signs or the vitals that are going to be associated with your excited delirium is everything is elevated. So hypertension, tachycardia, high respiratory rate, usually hyperverbal. So they sit there and blah, 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 blah. They're going to want to fight you. Not all the time, but they can be in that state. I already said high temperature. So hot, sweaty skin, excited delirium. I think I have a video of an excited delirium. This is a nicer excited delirium, but this shows you how quickly this patient can change. Say she's growling.
New Orleans.
Sounds like this might be some kind of like an email emergency. Yeah, for two. You can show us something on the PDF. Yeah, look at this. Or the notes indicate that this person is growling. We usually don't see that, so we're thinking, okay, what else is wrong? Walking into this call, we're definitely gonna have our hands on the stool. Do you know if she's saying anything? She's previously. What's your first name? Venus, like the lion, right? Like the love. There you go. All right, so your heart rate is extremely high right now. Did you say anything? No. That ain't always, baby. Her blood pressure is high, and she's acting very bizarre, which are all signs and symptoms of excited delirium. We have to get this person out of this house and into the
I wouldn't walk them,
so we can probably stabilize her. to a suspected overdose, and her heart rate is sky high. We gotta calm the storm down. Is that you? It's not high. It is high. It's not you. She's complaining of just like feeling super, super high, and like she can't breathe. It's cold outside. Hyperthermia is a sign of excited delirium. So excited delirium is pretty much when these people are in such a heightened state that all of their vital signs go up with it. And when those patients start getting extremely hyperthermic, that's when they're at risk for sudden cardiac arrest. Her pulse 140, 150, so we have to give her a sedative so we can get her back stabilized. Our heart's are coming down. Now I can actually listen to her own sounds. Yeah. Take a breath.
Done.
Start to notice on the monitor that her respiratory rate is dropping. Because I have suspicion that she has obesity.
Okay, we don't have to watch the whole thing. But you see the dynamic change. That was a different patient right there than it was when they walked in the door, right? So this was a nice 6-sided delirium patient. You're not always going to get that. And then these ladies were also very nice to this patient. So you get those providers that walk in and they're like, yep, she takes drugs. Come on, let's go. And they treat her like they're just an asshole to her. Do you think that dynamic would have changed, the scene dynamic? 100%. So these patients can switch like this. And so be mindful of these kinds of things, because she was starting to like decompensate while they're getting IV and doing the rest of the stuff. And I've said this before, and I'm going to say it again probably 100 times. Your patients don't suddenly die. You just suddenly notice. So there's always something leading up to that, right? So if you weren't doing a full assessment on this patient, didn't notice that she was hot, didn't notice that her heart rate was high and her blood pressure was high, and that she was altered, and then she started acting like this, and you're standing there like, I don't know what happened. She just died. Like, that makes you look silly. And it happens all the time. Do you have any comments on that video?
Yeah, it was bull crap.
What?
Because the goddamn firefighters would have carried her out of the house.
Yeah, that's true. I wouldn't have had her walk.
I worked around the city. Listen, respectfully, I worked in the city with a young lady. Then firefighters will do anything for you. I would walk out of the house and disappear the second it was time to pick up a patient, because as long as she was standing there, then firefighters were like, herp.
Yeah,
I was like, yeah.
I can pick her up.
Good job, guys. Just leave.
It's true. All right. So the appropriate facility, if you're dealing with something like excited delirium, you want to get them to a closer facility that's capable of handling that. But whenever we're talking about like our suicidal,
That's not Battle Mountain.
Yeah, it's not Battle Mountain. It's not. So go off your local protocol, capabilities of the hospital. If you have a mental health facility that's close, which we don't around here, try and take them there. You want them to get as good of care as they can, quicker, right? So the calls that everybody gets sued over is refusals and restraining patients. So whenever you are restraining somebody, make sure it's justified. Make sure it's reasonable.
And make sure you justify it in your chart.
Yeah.
That is where people lose those lawsuits, is because you're saying that you're restraining a patient, but not justifying why you're restraining these patients in your documentations.
Mm-hmm. Describe how the patient was acting when you got there. Patient was actively throwing hands with EMS providers. Patient was restrained for safety of EMS personnel and patient. Okay, things like that. Another thing they touch on is sometimes you get sexual misconduct complaints. So if you can have 2 providers in the back, they say the same sex provider. It doesn't matter. You're going to get those complaints either way. So if you have a way to get 2 providers in the back with you, or get somebody from like law enforcement to ride with you that has their little body cams, go for it. So I've always been taught if law enforcement has them in handcuffs, that the law enforcement officer needs to be in the back with you, because they have the keys to those handcuffs. So I just like to teach that. There's some places that are like, yep, they just have to follow really close behind. I don't give a damn. If my patient crumps and I need their hands out of the handcuffs, I want it done now. I'm not going to pull over and be like, hey,
Because why? Because we don't stop an ambulance just because somebody dies.
yeah.
We don't keep on moving.
There's few exception, but if they are like handcuffed or in custody, I'll try and just get them into my soft restraints. If PD is like absolutely like not going to ride with you for whatever reason, unless they're like straight out of the prison and they got like the full shackles on, then they're riding with me. Questions?
Oh, he's asleep. So listen, I'm a big advocate for mental health stuff. I'm a big advocate for mental health for y'all. I'm a big advocate for mental health for patients. I spent, a week and some change in a mental health class for first responders. I love it. I think that it's a very, very, I think that it is a very overlooked aspect of what we do. But understand that when you're dealing with these patients, I want you to be safe. I want you to keep your patients safe, but I also want you to treat these people with respect and dignity. Okay. I don't know what adult in here hasn't been sad before, but if you have, please let me know what drugs you're taking because I want to take them. Everybody here has gone through stuff. Everybody here has been down, depressed, some of us more than others. And some people go off the deep end and resort to calling an ambulance looking for help. And honestly, the way that our mental health system is set up and the way that they treat these patients in the hospitals and with these mental health facilities, a lot of what you do in the back might be the best care that these people get. So treat these people with respect. Okay, they might be sad. I've had my hand slapped for walking into calls before. Just like, God dang it, it's freaking anxiety. And I've had my hand slapped, and I don't do it no more. She slapped my hand for it. But after really, really, sitting down and thinking about what's going on with these people, you will come to understand that a lot of what you do as a pre-hospital provider will probably be the only respectable care they get if you treat these people appropriately. So do it. I mean, that's your job. That's what you're getting paid to do. And if you don't want to, find a new job. That's kind of how I feel about it. So
I did want to talk about like legal 2000 forms. Does everybody know what that is? No. Okay, so in the state of Nevada, when there's like a mental hold on somebody, they need to go through like a legal 2000 form, and that differs from state to state. And for the family to put somebody on that, like, hey, they're suicidal and they need to be like on a suicidal watch, they need to go through like the sheriff's office to do that. So if you're in a situation, like you show up on scene, different states are different agencies are different. So it's good to know the things surrounding a legal 2000 form, because in Georgia we couldn't put them on somebody, we can't put them on somebody here. You need an officer on scene with you. So if you truly believe that somebody is like, yep, they're a danger to themselves, but they're not answering those questions, or they're answering all the questions appropriately for you, that's something that you guys need to know the route to take. So your officers are a fantastic resource whenever it comes to anything like that, whether it's on a call or like your own personal family member. So yeah, that's it. Did I miss anything?
anybody have any questions about this? I know it's kind of sad, right? Sad face, people go through stuff, but be respectful for these people, please. All right. Everybody grab a chair.
Yes, we can get you a copy.
Everybody grab a table. We're going to move some stuff real quick before y'all leave because it takes us
they
about
just
30 seconds while everybody's here to do it. Where it takes us 30 minutes to do it while y'all leave.
Put in for like our new and updated ones. So whenever we get those pushed through, I'll get y'all a copy.
These four tables all go If you have any questions
Thanks,
about the
Jonathan.
arrangement of this facility,
Moving chairs from Texas. Awesome. Do you guys have any questions? You can go ahead and text in the chat if you have any questions, or get a hold of me or Chaz. So thank you guys.